at an early stage when known intervention is available that can have a positive effect on the outcome of the disease. And in terms of osteoporosis, screening implies that individual at increased risk of osteoporosis and or fracture be identified and managed in such a way as to prevent osteoporosis. We can identify these women. Mark will show you how to treat these women to prevent fractures. So if we have a look at the latest recommendation regarding screening, it was only published this year on January the 14th, and that is the United States Preventative Task Force on Screening. Now, what they said was the first bit is not really relevant to it, but well, firstly, that they define screening as central DEXA examination with or without risk factors. So that's important. The second one is that they basically say any woman over the age of 65 should have a DEXA. But when it comes to the younger patient below 65, things get slightly more complicated. And what they now recommend is that you should screen. In other words, you should do a DEXA on the younger women who are at increased risk for an osteoporotic fracture as estimated by clinical risk assessment. Now, in their previous recommendations, they only said that the woman should have one or should have at least 2 risk factors in order to qualify for a DEXA, but now they say that you must do a clinical risk assessment. So how can we do that? They advise that we do it in 3 steps. First, to identify the younger woman with more than 1 risk factor, then to use a calculation model to determine the need for central DEXA, and then to do a DEXA. So that's what they say. So let's have a look at that. So firstly, the risk factors for fracture. These are taken straight off the FRAX modeling, and I don't think there's anything controversial here, but age, in this case, the women would all be about the same age, and the sex, they would all be females, but the weight is important, the height is important, get the BMI, a previous fracture, parental fractured hip, current smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis, alcohol, smoking, and then bone mineral density. So these are the 3 models then that the task force presents to us. So the first one is one which is actually not used a lot, but which to me looks quite attractive. That's the OST method, which is fairly simple. That all you do is you take the weight in kilos, subtract the years of age, and then you multiply by 0.2, a factor of 0.2, and at a value of less than 2, you have identified. The ORIA test is just slightly more complicated in the sense that there are different values given to the ages and the weights. I think that the OST to me sounds. Also say that you can use FRAX, paperless FRAX. That's in other words, the FRAX model to define the increased risk of osteoporotic fractures. Now, this, as you know, is more complicated. I have to fill in every one of these factors. Then the model will give you a risk over the next 10 years for major osteoporotic fracture or for hip fracture. But the problem is they don't give us a cutoff value. Now, if we use the previous cutoff value of 8.7% that they said, the FRAX has a very poor sensitivity of only about 5% to 9%, a specificity of 63 to 96% with the area under the curve of 0.55 to 0.62, which makes this model, the FRAX model, in the younger patient as a predictor of osteoporosis not better than chance. Whereas the OST has a sensitivity of 79%, specificity of 70%, with an area on the curve of 0.75 for predicting bone mineral density at the femur neck. So I think that is a fair assessment. This is just my own calculations on the South African FRAX model. They, at the 2018 recommendations, they said to use a threshold value of 8.4% over 10 years for major osteoporotic fractures. But even if we take low bone mineral density, a parenteral hip fracture, smoking and drinking, and the patient is 50 years old, this only gives a risk factor of 44% using FRAX on the South African model. So I think it virtually doesn't help us at all. And this is then also be emphasized in a editorial. Ensrud said that fracture risk assessment of osteoporosis screening, and specifically in the younger patient, is much easier said than done. So why then is FRAX without DEXA not appropriate at the peri-post-menopause? Well, FRAX is a risk factor for, and obviously patients at 50 can be at low risk according to the risk factors, but still have a low bone mineral density. Whereas a DEXA-based bone mineral density is based on the risk for osteoporosis, and it doesn't take into account the future risk. So it is my personal and humble opinion then that if we deal with a recently postmenopausal patient or one in late perimenopause, that I feel that there should actually be a reason not to do a DEXA during this during the peri and the postmenopausal time period, as that is the way in which you will be able to identify the patients at risk and whom we are perfectly capable of treating and preventing fractures, as Mike will show in the second part of our webinar. Thank you very much.
He presented in the Q&A session. Many thanks, Tobie, for an excellent talk, which is considerations afterwards. So the next speaker is McClung. He will speak about diagnosis and intervention. Dr. McClung is an endocrinologist with a special interest in metabolic bone diseases and disorders of calcium metabolism. As founding and now emeritus director of the Oregon Osteoporosis Center in Portland, Dr. McClung has, for the past 4 decades, cared for patients with osteoporosis and related conditions. He developed quality control procedures for bone density testing, was involved in many major clinical trials of osteoporosis treatments, and has participated in the development of osteoporosis guidelines for several national and international organizations, including the International Menopause Society, the North American Menopause Society, and he is currently a professorial fellow at the Mary McKillop Center for Health Research at the Australian Catholic University in Melbourne. So, Professor McClung, please have the floor.
Yes, thank you very much, Professor Cano. It's a very great pleasure to be here and to share this symposium with my friend and colleague, Tobie de Villiers. So, as mentioned, I am going to deal with how we can act upon the considerations that Tobie outlined to intervene to prevent osteoporosis from happening in the first place. Here are my disclosures, most importantly that I am on the board of the International Osteoporosis Foundation. So as Tobie has outlined, bone loss is a continuous process that begins around the time of menopause and continues throughout the remainder of a woman's life. As he mentioned, roughly half of all of the bone loss that happens between menopause and age 80 happens across the menopausal transition, where the rate of bone loss is relatively quickly. And as important, deterioration in architecture assessed by trabecular bone score, as he outlined, half of that deterioration happens within the first few years of menopause, meaning that that menopausal transition is associated with significant decreases in bone density and deterioration in structure. And this is an opportunity for us to intervene to prevent that process. So let me attempt to clarify the difference between osteoporosis treatment, which we normally talk about, which is where we identify patients who are at risk for fracture with fracks and other tools, and then we intervene to prevent fractures. In contrast to that, preventing osteoporosis is the objective is to identify women who are not at high risk today, and that's why fracks is not a good tool for this situation, but where we attempt to identify women who are at high risk for developing osteoporosis. And then we treat them not to prevent fractures immediately, but to maintain their bone density and to prevent the development of high fracture risk. There are a number of medications that have government approval for that. That includes estrogens, oral or transdermal. In some countries, estrogen combined with a SERM, benzodiazepine, with raloxifene and tibolone. And then all four of the major bisphosphonates are approved, but note that the highlighted ones, alendronate and zoledronate, the approved doses, at least in my country, are only half of the dose approved for treatment. So as Tobie outlined, if women come to menopause with an average bone density, with the relatively rapid loss that happens across menopause that Swan has taught us, and then with continued bone loss, the average age at which an average woman will reach a T-score of -2.5, the diagnostic threshold for osteoporosis, is about age 82. But if they come with a lower bone density, then they will develop osteoporosis earlier in life, and those are the women that we can identify, as Tobie outlined, by knowing their bone density at the time of menopause. So, but again, a woman who comes to menopause with a T-score of -1 or -1.3 at that moment is at low risk of fracture. So why should we consider treating her? Why don't we just wait until she has osteoporosis and then we can treat her in the usual way? Well, here's what happens. For women who come to menopause with a T-score of -1 or a little lower, after losing 18% of their bone density, they will have osteoporosis. And if we intervene with a bisphosphonate at that point, they will regain maybe 6% of their bone density and have a T-score now of -2.4 and will remain there with continued bisphosphonate therapy at relatively high risk of fracture. Even if we employ our most effective treatment, which is the combination of romosozumab followed by denosumab, the maximum increase in hip bone density seen is about 9%, having her now be with a T-score of -2.2. Whereas, if we could prevent the bone loss that happens across the menopausal transition, she will remain with her T-score of -1.3 or -1 and will then enter older age at a much lower risk of fracture. So how can we do that? It would be ideal, and most women would want to believe, that if they just do the right things with good nutrition, regular physical activity, and avoiding harmful habits, that bone loss should be prevented. Unfortunately, that's not true. Studies with exercise, with calcium, with vitamin D, all show that while they are important and may have small benefits, particularly in older women, none are sufficient and successful in preventing the relatively rapid bone loss that occurs over the menopausal transition. So that's where we consider pharmacologic intervention, and of course, the most appropriate would be simply correcting the estrogen deficiency that is the underlying pathophysiologic reason for the perimenopausal bone loss. The PEPI trial many years ago now documented that in women in early menopause, administering estrogen with or without progesterone was effective in preventing the loss that occurred and even resulted in a modest increase in bone density. Many studies with many forms of estrogen have been done. Meta-analyses document clearly that estrogen is effective in preventing the bone loss that happens in early menopausal women, and it is effective as long as treatment is administered. 30 years ago, when we considered this, we asked the question, well, okay, we can prevent bone loss, but we don't have evidence that that results in fracture protection. The Women's Health Initiative, for all of its foibles, did demonstrate that treating women, on average, their age was 63 years, who were at very low fracture risk, resulted in substantial reduction in fractures, even in this very low risk population. A number of other studies that I and others have been involved in have shown that bisphosphonates are similarly effective in preventing the bone loss that happens in early menopause. These are data from the EPIC trial, where women who were enrolled in the study, on average, they were 6 years since menopause, were given either estrogen or low-dose alendronate, and over 4 years, there was protection from bone loss, while in the placebo group, a significant decline in bone density was achieved. There are numerous studies looking at the dose response curves of estrogen. The most effective doses from those clinical trials are doses of 2 milligrams daily of oral estradiol and 0.1 milligram daily of transdermal estradiol. Lower doses have some effect, but particularly in early menopause, when bone turnover is high and bone loss is rapid, these lower doses are not effective, not as effective in protecting women from bone loss. Pure progestins have no effect on bone density. They don't add to or subtract from the effectiveness of estrogen, while androgenic progestins like norethindrone acetate have a very small added protective benefit. And with both bisphosphonates and with estrogen, the bone density effects of preventing bone loss persist as long as treatment is given. However, when estrogen is discontinued, as is true with most every drug, the benefits go away very rapidly. Here in the EPIC study, we treated women with estrogen for 4 years, then stopped. The 6% increase in lumbar spine bone density that had been achieved over 4 years was all lost within the first year off therapy. And by the end of the second year off therapy, the patient's bone density was approaching that seen in the placebo group, meaning that, again, there's little residual effect. It's also seen in terms of fracture protection. The bar graph on the right are data from the Women's Health Initiative. After the study was completed, women were followed off therapy for an additional 2 years. What's shown here is the annualized rate of vertebral fractures in the women either on placebo or on estrogen, showing the 34% protection with estrogen while they were receiving therapy. During the 2 years off therapy, the rate of vertebral fracture in the women who had been on estrogen increased up to the level of the placebo group, again showing rapid loss of vertebral fracture protection when treatment is discontinued. We can make that not happen by transitioning patients from estrogen to a bisphosphonate. Here in the study that we did right after the Women's Health Initiative came out and women were discontinuing estrogen, we randomized women who had recently stopped estrogen to receive either alendronate or raloxifene and followed them for a total of 2 years. The women transitioned to alendronate did not experience bone loss, in fact, had a modest gain in bone density, while the women who were transitioned to raloxifene had a modest decrease. Not surprising, since raloxifene is a weaker anti-resorptive drug than is in both groups. There is actually a reduction in the risk of heart disease in the women who were young when they began in therapy. And not only was there a reduction in fracture rate, but overall mortality was reduced in those women as well. So that is an important consideration. Osteoporosis guidelines, again, tell us to identify women at high fracture risk and to treat them to prevent fractures. The only set of guidelines that has addressed the question of prevention was the guideline from the North American Menopause Society, published back in 2021, where we said that estrogen or bisphosphonate could be considered to prevent bone loss in young postmenopausal women who have low bone density and other risk factors for fracture, even though they don't meet the criteria for osteoporosis treatment. It's my personal view that this means that we should not confine the use of menopausal hormone therapy only to women who are symptomatic, but we should consider the use of menopausal hormone therapy to prevent bone loss in the appropriate patients who are at high risk for osteoporosis, even if they don't have vasomotor symptoms. So how can we do that? Let's imagine that we treat our patient with menopausal hormone therapy beginning at the time of menopause, and arbitrarily we treat her until age 65. There's no limit to the duration of hormone therapy, but for the purposes of illustration, let's figure out what to do if hormone therapy is discontinued at age 65. There, 2 years of low-dose alendronate followed by discontinuation would be appropriate, and we know that that maintains the bone density that the estrogen therapy had protected. Or 1 dose of intravenous alendronate given at the time estrogen is discontinued would be effective in protecting that woman from bone loss for the next 2 years. But then the question is what to do for the remainder of a woman's life. I contend that we need to actually have a life plan for osteoporosis management in these patients. This is where I think the concept of maintenance therapy comes in. And we have ways to take advantage of the quite slow off effect of potent bisphosphonates like alendronate or zoledronate. And I'll show you data arguing that giving bisphosphonates intermittently can maintain bone density over many years. The first of those studies used alendronate, where we treated a number of women who were between ages 40 and 59, average age 55, average 7 years since menopause. They were treated for 2 years, and then therapy was discontinued, and they were followed for an additional 3 years. The placebo group, as you see, experienced bone loss in both the spine and the hip. With therapy, there were modest increase in hip bone density, slightly greater increase in spine bone density, and then upon discontinuation, hip density remained stable for at least 3 years, and the spine bone density gradually fell back to pre-treatment levels over 3 years. So by doing intermittent therapy of 2 years of low-dose alendronate, one can actually maintain bone density. Even more interestingly, this is a study published just in January of this year from Mark Boland and the group in Auckland, where they enrolled 10 years ago more than 1,000 women whose average age, but they gave them 1 dose of intravenous alendronate every 5 years and then followed them for 10 years. And they showed, again, stability of hip bone density values with those 2 doses of zoledronate, while the placebo group had a decrease in hip density of almost 8% over that interval of time. Importantly, there was also a risk of major osteoporotic fracture, 42% in this very low risk group of patients. So very similar information from what we learned from estrogen administration in the Women's Health Initiative. And importantly, this or atypical femoral fracture. So a lifetime plan for preventing osteoporosis could include menopausal hormone therapy until whenever it's decided to discontinue therapy, followed by consolidation with either alendronate or zoledronate, followed then by the intermittent bisphosphonate maintenance that could then maintain and preserve that patient's bone density and keep her at lower fracture risk for the remainder of her lifetime. And again, the short intermittent exposure to bisphosphonates minimizes the concern about duration-related adverse events, and the total cost of the full 30 years of management in the United States costs less than $4,000. When this strategy was considered in the 1990s, it was thought to be prohibitively expensive because the cost of medications at that time was much, much more than it is now. But this is a much less expensive approach than waiting until someone has severe osteoporosis and then employing osteoanabolic therapy, for example, to attempt to correct the problem. For women who can't or should not take estrogen, one can begin the intermittent bisphosphonate therapy at the time of menopause, and then with zoledronate perhaps in the transmenopausal period, another dose a few years later, then every 5 years, one can maintain bone density over the remainder of her life. While we now hesitate to begin hormone therapy in women who are more than 10 years beyond menopause because the benefits are not seen in that group, we don't have to worry about that with the intermittent bisphosphonate therapy. This could be begun at any time after menopause. So to summarize, as Tobie has outlined, we can very easily and inexpensively identify women at the time that they enter menopause who are at high risk for developing osteoporosis. They are not at that moment at high risk for fracture, and their FRAX scores will not tell us that they are candidates for therapy, because that's not what FRAX was meant to do. But we can identify women who are likely to develop osteoporosis. And we have, I contend, safe and very effective management strategies to prevent the relatively rapid bone loss that occurs over the menopausal transition, and then to maintain that for the remainder of their life. So in at-risk patients, then evaluation and treatment for prevention would ideally begin at the time of the menopausal transition, not at age 60 or 65. And then once that prevention of the rapid bone loss at menopause has been accomplished, then the intermittent bisphosphonate maintenance therapy can maintain that process for the remainder of its life. So I contend, and I expect that Dr. de Villiers agrees with me, that by not providing therapy to prevent perimenopausal bone loss, particularly in at-risk patients, we are missing a unique opportunity to protect women from the consequences of osteoporosis. Thank you very much for your attention, and I look forward to our discussion.
Thank you, Professor McClung. And thank you, Dr. de Villiers. So, we have plenty of questions queuing, and means that certainly the topic matching, and I should congratulate because I have enjoyed both talks, and I think going to a point which is very interesting for clinicians, because we face every day women who come to us. They are young, they are supposedly not at risk of fracture, but they want clear answers. So perhaps we may just start. the questions. In case the question is directed to one of you, we'll just direct that to the person which is. But if not, I will just start with the other. So we will start here. Question by Dr. Patel, and for example, for Dr. de Villiers, who was the first. And the question is: are molecular bone score routinely measured when DEXA scan?
Okay, I think it be routinely done. Fortunately, not all DEXA machines in has the software addition to do that. It is a little bit pricey for the operator to acquire the software, but I think it's absolutely well worth the while because it gives an independent evaluation of bone microarchitectural, which is different from that information that you obtain by looking at bone mineral. So I think that you can put some pressure on a local supplier of DEXA to try to get a molecular bone score. It's very easy to actually get it.
If you saw a patient menopause with a T-score of minus 1.2, but who had a normal bone score, influence you not to intervene in how you used TBS at that moment?
Yeah, so I would expect the bone mineral density to lower before the TBS actually is reflected. See the patient, for instance, for the first time 4 years after menopause, then perhaps the value of the trabecular bone score would be a bit higher. But Mike, as with anything in medicine, the more information you have, the better. But you always have to use your discretion.
Fair enough. I just want to make the point that before bone loss begins in earnest, the trabecular architecture is not degraded yet, and so TBS will be normal as women enter menopause. So having a normal TBS would not dissuade me from taking action to prevent the bone loss that we're expecting to happen.
Okay, thank you. So the next question is for you, Professor McClung. So do we use SET when interpreting DEXA less than 50 years women and T-score 50?
Police from the Bone Density Society made that recommendation many years ago. The reason that they recommended using Z scores or Z scores in premenopausal women was so that we would not make the diagnosis of osteoporosis in those groups. So, but of course, in premenopausal women, the T-score and Z Caucasian women are almost always the same, so it doesn't really matter. As women approach menopause, and even in perimenopause, I think using the T-score is more using, and I would recommend.
Official from the policeman, from the IACD, that in the perimenopause, especially the late perimenopause, you should use the T-score.
Yeah, that's
yeah.
So.
This is for you, Tobie, is an anonymous. Who says, what about? Yep.
So I see the questions. What about the Q fracture score?
Can you read it? Okay. What are your thoughts on this?
Okay, I unfortunately do not have an answer there because it's not a score system that I or any of my colleagues frequently use. So I think if you want to use something, the OST is probably the best one because it's the easiest to use, and it takes into account the mass of the patient, which I think is a very important factor there. Mike, I don't know whether you use the Q score at any.
No, again, but yeah, I think, as we've said earlier, using fracture risk calculators to make decisions at the perimenopause is not helpful because the women are not at high risk at that time. Those scores were used to identify patients who would be candidate for osteoporosis treatment, not for osteoporosis prevention. And so the OST, as you mentioned, was a tool designed to identify women who were at high risk for having low bone density, not for fracture. So that using OST, which just looks at age and weight. So if you take women at perimenopause who are around age 50 or 51, then weight turns out to be the strongest predictor of their low bone density. And that's why guidelines suggest that measuring bone density at the time of menopause in the lowest quartile of weight in the US, that's a part of the guidelines.
Okay, thank you. The next one is also for you, Tobie. I think as you see it, can you read it? It's for Asian
Yes.
countries. Okay.
So
I will read it for the audience. It's where we have economic challenges and availability of DEXA machines. What modality is best for screening for you, Dr. de Villiers? This is a
Okay.
question from Dr.
As-
Ayuba from India.
as I said that I think you should have a good reason not to do a DEXA round about the peri and the menopause, but a very good reasons, obviously, if it's not available. So that is what situation is there. So unfortunately, you can only go on clinical risk factors, and as Mike pointed out, the clinical risk factors are actually of fracture, which is not relevant at that point. So that you should, though, heed to or pay to a low body weight, and you should pay attention to a family history of fracture. And then obviously, patient has secondary medical causes for being at risk. But for much of the time, you will not be able to positively assess patient's risk without a DEXA. Then it's very easy because then you're going to get the added benefit of bone protection. But if the family history, etc., is such, then I think I would just go straight onto menopausal hormone therapy.
I would agree with that. And of course, many women are given menopausal hormone therapy for the management of symptoms. And if that's the case, the bone protection comes as an added benefit. However, whenever you stop estrogen, then attention needs to be paid to their bone to protect and maintain the benefit that the estrogen is provided. So oftentimes, if women are treated for symptoms only, then as their symptoms get better, estrogen is stopped and people forget about the skeletal part, and we shouldn't forget at that point.
Okay, thank you, Professor McClung. This is for you. If I interpret correctly, is how to manage lady 57 years female, bone aches, had DEXA showing osteopenia in order to prevent osteoporosis and fracture. So 57 years, bone aches, yes, and osteopenia. What to do?
Well, part of that depends again on how recently her menopause was. If her menopause happened in 10 years ago, she is probably past the phase of relatively rapid bone loss, and there's less urgency bone loss at that point. If she was 55 and she went through menopause, she's still in this rapid phase of bone loss, she certainly would be a candidate. Prevent. So one can use mark time to help make that decision about how quickly bone loss is happening. So, or if again she has other risk factors, even at age 57, that strategy that was outlined in the paper from New Zealand of giving doses of zoledronate every 5 years is such an easy, inexpensive way to do it that if I were that patient, that's what I would do.
Thank you. So next one for you, Tobie, is Dr. Sabadekar what's the quality of bone formed with the different antiresorptives? Are there differences between them?
Okay, so that's a point that would be argued by many of the different companies, but I think what we can say that none of the antiresorptives will restore the trabecular bone structure. So that is the discerning point between the antiresorptives on the one side and then the anabolics on the other side. What I just would say, so if we think about the different bone qualities, probably the clinical important point there is the incidence of atypical femur fractures, because that maybe in an indirect way can reflect upon the cortical porosity. But so the bisphosphonates are the drugs that are more prone on the longer duration to the atypical femur fractures, whereas our other antiresorptives such as estrogen or our denosumab has a smaller incidence of atypical femur fractures. So I don't think that completely answers your question, but I think it touches upon some of the considerations that you can use.
Let me add to that and emphasize a point Tobie made. The antiresorptive drugs should really be called anti-remodeling drugs because they not only inhibit resorption, but they also inhibit formation. And we forget that. And if a drug inhibits bone formation, then it has no chance of restoring the microarchitecture. So yes, bone density goes up.
Confirm what you have mentioned in your talk. The question is, did we say fracs not useful to screen for osteoporosis at perimenopause as may underestimate risk as more focus on fracture risk?
Yep. FRAX was a tool designed to identify individuals at high risk of fracture, not to identify people with low bone density. And so that's why I tried to make it clear that there's a very different approach to identifying patients who would be candidates for osteoporosis treatment on the one hand, and a different approach and different risk factors and different tools to identify women who would be candidates for osteoporosis prevention.
Thank you.
So the most important predictors of osteoporosis and fractures in early menopause from the SWAN data that Tobie mentioned were bone density at the time they enter menopause and their body weight. Those were the two major risk factors.
Okay, thank you. Now is a question by Dr. Harding to you, Tobie. It's a 65 plus. What is the recommendation for women with osteoporosis, with the diagnosis of osteoporosis at this age?
So what's the recommendation for women already diagnosed with osteoporosis at age 65? Well, I'm not going to go into all the details of that because it's not really the purpose of this webinar, but the recommendation would be first to see what causes the osteoporosis, so any secondary causes be treated, to change the lifestyle, and then probably to pick your choice with various factors of an antiresorbent, and only if it is a patient at very high risk of fracture would an anabolic agent be preferred before you start your antiresorptive. So I'm not going to go into any more detail because I would be rambling on for the rest of the night.
All right, that's a whole other lecture, isn't it?
Yeah.
Yeah, yes. Well, now it's a question about dose or which type of estrogen. Is transdermal E2.1 milligram a day, 100 micrograms, similar to 2 pumps estrogen Evorel 50?
Yeah, the attempts to compare doses of different forms of estrogen we have very, very little information about that. So in the dose response studies, 0.1 milligrams of transdermal estrogen is sort of at the top of the dose response curve. With oral estrogen, 2 milligrams a day is slightly better than 1 milligram a day. So it's in that ballpark. I think, in my experience, is that women in early menopause, in the transmenopause, need higher doses of estrogen to protect them from bone loss than do older women. So beginning with the doses at the upper range, I think is appropriate for women in their early menopause. But then 5 or 10 years later, I frequently reduce the dose by half and are able to maintain bone density with that smaller dose in older women who are beyond the phase of rapid bone loss.
Well, then there is a comment by the same doctor explaining that when she was perimenopausal and then menopausal, her doctor denied the option of estrogens, and now she's dealing with osteoporosis. So that confirms what has been maintained in the two talks. Then we have a question of Adele Martin. Blood work checking after giving any treatment is not the standard practice in the UK. Decided to use a standard prescription HRT. 14 years later, through blood work, I did the HRT, and now my G score is 2 something. Now, through a private doctor, I have a and it's sort as I have blood work check quarterly. To comment with
I don't. Yeah, the point is made here to treat according to targets. I don't think that that is quite what any societies state. So, in contrast to, for instance, compounded versus done any of the dose range finding studies, which so you do not know what are giving and whether what you are attaining. In contrast to that, using standard regularized medication, it is quite easy to know which dosage to go on. And in terms of your control of symptoms, is a very good indication of where you should be. So if the dose is enough to suppress the hot flashes, then it certainly is going to be enough for bone, because generally you need not that high levels. For bone is very sensitive, and even at very low levels, you have an effect on that. So I would discourage the idea that you go for your blood works every quarter. I think you are wasting money. If it's done once or twice, you would able to have a good idea, and it's very unlikely to change between every quarter. You should also just be very careful in looking at the exact assay that is being used by your laboratory, whether it actually picks up that which you are taking, because not all laboratories will use, for instance, an assay that will detect all the exogenous hormones that we give.
Right.
Thank you. Well, we have plenty of questions. I think we will give 10 more minutes. But I think this question is perfect for Professor McClung, because it's from Dr. McDonald. Where do you see the role of non-medication interventions for prevention and treatment as appropriate of osteoporosis? Interesting systematic reviews by Sao, 2019, Journal of Orthopedic Sports Physical Therapy, suggest that resistance and or plyometric jump training in preserving bone density.
Right. Again, I didn't spend much time about that. Certainly, all of the general measures are important in optimizing responses to things. The data about resistance and loading exercises is very interesting. In children who are growing, there's a very big benefit of loading exercises that helps children obtain even greater peak bone mass. That's probably the time in life where that exercise is important. For older women, there is a modest effect of resistance exercises on bone density. One can see increases in the spine of maybe 2 or 3%, but none of those studies have shown that you can prevent the rapid bone loss that happens at the time of menopause. So while exercise is important, it is not sufficient to protect women from the bone loss that's due to the acute estrogen deficiency that we know happens at the time of menopause.
Then I just jumping over the questions. There is one here, probably of much interest to most of the audience. Please clarify, Tobie, what counts as low dose alendronate?
So is that the question to me?
Well, not directly to you, it's in general, probably.
I'll answer it since I did the study. So that the doses approved is 5 milligrams a day or 35 milligrams a week. In the United States, that 35 milligram tablet is available, but for some reason is much more expensive than the 70 milligram tablet. So actually what we do is give patients one 70 milligram treatment size tablet every 2 weeks. That's the low dose alendronate.
Mhm. Okay, now for you, Tobie, 60-year-old lady settled on HRT for menopause symptom control is then found to have osteopenia, minus 0.5 to minus 2.5. Is it appropriate to add denosumab? She is intolerant of bisphosphonates. Thank you. Professor McClung says no.
Okay, I think that most likely the estrogen is going to be sufficient to protect her against fractures, especially in the low bone density or then osteopenic range. And I do not think that this patient qualifies for the addition of denosumab or bisphosphonate at this stage. But we do see some patients who, in spite of adequate menopausal hormone replacement therapy, may still be losing bone at a disturbing rate. And so I would follow this patient up with another bone density in, say, 2 years' time. And if it is definitely the values keep on going south, then I would reconsider taking into account all other factors that may be. But again, first exclude secondary causes of bone loss, because very often that is your clue to that there's something else amiss.
And studies were done combining estrogen and bisphosphonates. And if women take the full dose of estrogen, back in those years, it was 0.625 milligrams of conjugated estrogen, that dose of estrogen inhibits bone resorption. And there's very little additional bone resorption for a bisphosphonate to inhibit. And so not surprisingly, when alendronate was added to estrogen, there was a very tiny additional benefit on bone density. They certainly are not additive. And so if bone loss is happening on estrogen, rather than adding a bisphosphonate, one consideration would be to simply increase the dose of estrogen as the solution to that.
So we have time for 2 more questions, so one for each. Professor McClung, how do you prefer alendronate and zoledronic instead of ivandronate in preventive therapy? So do you have anything against ivandronate? Or?
The data with abandonate is much less strong than with either of the others. Abandonate is not as potent as either alendronate or zoledronate, and we've got very good long-term data with both alendronate and zoledronate. So I'm not a fan, and I don't use abandonate.
Okay, thank you. Now for you, Tobie, the oncologic patient receiving anti-hormonal medication. Okay, breast cancer and okay.
Okay, I think that this is a question I think both me and Mike, and I think you, Antonio, I'm not sure, sits on a subcommittee of IOF who has just recently done a review paper on exactly which patients should receive extra protection against osteoporosis. And I think that one should firstly state that it's not all anti-hormone medication that actually will lead to bone loss. It is the aromatase inhibitors as a class. If tamoxifen is used, there can actually sometimes be a slight gain in bone mineral density. But in tamoxifen patients, all these patients at the start of aromatase, or the aromatase inhibitor, all breast cancer patients at the start of that therapy should be assessed for the normal risk factors for fracture. And I think we said that if they have even a low bone density, even if they have a bone density up to minus 1.5, but below -2, they should only be treated if they have 2 risk factors. But if the bone mineral density is less than 2, irrespective of risk factors, they should receive additional therapy of either an bisphosphonate, in this case, zoledronic acid is probably the best one, or denosumab, which is also works well. Those are the only 2 classes that we have any data on. So this is a special group of patients on aromatase inhibitors, so they should be carefully screened for the need of additional therapy.
Okay, thank you. Which we have focused on that important period of the perimenopause and early menopause. So many thanks to the speakers, many thanks to the attendees, and many thanks to BT Congress for preparing all the infrastructure. Thank you.
All right. Bye, all.
Bye-bye.
See you in Rome.
Yeah.
Yeah.